this will be an educational 25 minutes, I hope. We're in a state of tension and stress. So I've created this video to help people understand how to assess and maybe even some treatment options for the amount of stress that we're under and how that affects the thyroid gland. I first started noticing a very odd phenomenon in 2016. It took me a little bit of time to figure out when it actually had started, but it actually started with the presidential campaign of 2016. By the end of this video, you'll understand what, in fact, we were observing here in the Cameron Wellness Center. A little bit about my history. I'm Dr. Todd Cameron. I started in medicine back in the 70s as an EMT, working in rural places, forming quick response units. I ended up in nursing school. I was an ICU nurse, and then I pressed the reset button and ended up going into medicine. And you can study this page if you like. We'd like to talk today about common symptoms of adrenal and thyroid problems. They're prevalent in our society, but they're kind of hidden. You know, I always ask people, and they usually will express to me that they're experiencing fatigue in the morning. I'm tired in the morning, I'm tired in the afternoon, I have a general sense of fatigue, I'm lethargic. My get up and go got up and left. I want to do something, but really it's just easier to flip through the channels. What's that guy's name? Where did I put my keys? What did that paragraph say? And why can I gain weight so easily, but I can't lose weight? And why is my fuse getting shorter and shorter and shorter? So it's my job as a physician, working along with my patients, to discover how much of these symptoms that are so prevalent in our society today, how much of them are hormonal, how much of them are in the adrenal sphere, and how much of them are in the thyroid sphere. And because they're all overlapping. And we're not going to talk today about the hormonal sphere, but we are going to be talking about the thyroid and the adrenal sphere. So what do the adrenal glands do? Adrenal glands are involved in our stress response. Everybody knows about epinephrine, fight or flight. But few people are aware that cortisol is also a very important part of the stress response. And the more we get into adrenal insufficiency, in other words, the more stress that we have that's unmitigated, the more we have our cortisols messed up. They become outside of normal range. And if they go high, that affects the way that the thyroid hormone can function in a cell, and if they go low. So the first job is to figure out if and how far into adrenal insufficiency somebody is. The thyroid is involved in metabolism. So the thyroid makes T1, T2, T3, and T4, so designated by the number of thyroid or iodine molecules that are on that thyroid molecule. So T4 has 4 iodines, T3 has 3 iodines, T2 has 2, and T1 has 1. We don't know a lot about what T1 and T2 do in humans, but we do know a lot about what T4 and T3 do in humans. And the thyroid mostly makes T4. We measure the free version. If I'm a thyroid hormone and I'm stuck to a protein, I can't do anything. But if I'm free and I'm unstuck to a protein, then I can be biologically active. T3 is easily 4 times as biologically active as T4. And so it's the free version of T3 that we're really mostly concerned about, what the levels are. And we look at ratios, as we'll see as we go on in the slideshow. We'll see that the ratios that I'm looking at are important, a lot more important, as a matter of fact, than the actual lab number. So a word about biochemical individuality. We're all similar. You know, I've got a couple of ears, I got a nose, just like you. But we're also very, very biochemically individual. And so I'm often asked, you know, if I'm prescribing a thyroid hormone, it's like, well, how much should I take? And it's like, I can't tell you that. The only thing I can tell you, I can prescribe it, and I can tell you what it feels like when you're taking too much. But in terms of how much you need, what type you need, and when you want to take it through the day, that is completely individual. There is no way that I can tell you that. So we have to experiment together. It's one big job of experimentation, of exploration in terms of adjusting the optimization of thyroid hormone. And in adrenals, it's the same way. There's one person that will be able to put up with a massive amount of stress and be able to keep the hormones from the adrenal gland in normal range. And then somebody else can have a slight stress, and that can send them right over the tipping point. So when I'm communicating with my patients and I'm asking them, you know, they normally say something like, I've never been the same since blank. I've never been the same since the birth of my child, or the birth of my fourth child, or my trip to China, or since I had the influenza, or whatever. There's either one or a subset of things that is going to have tipped them over the tipping point, and they may not even remember what it was. I was just talking with a patient today that came to a realization, oh, by the way, 2.5 years ago, I had a very stressful job, and my boyfriend and I decided to get married. Well, that's a good stress, getting married, but it's still a stress, right? So she's never been the same since then. She's gained 25 pounds. Her energy has dropped dramatically, and yet nothing else has changed in her life. By the way, she did get a better job. So it isn't just about nurture, or it's not just about nature. It's about ourselves living in the environment that we're in. And like I previously said at the beginning, the environment that we're in right now is over the top stressful. You'll be seeing evidence of this in a few slides. Medicine is a science of uncertainty and the art of probability. William Osler was an osteopathic medical doctor and arguably the father of modern medicine, and he is one of my great heroes. William Osler was, in my opinion, one of the first in Western medicine, one of the first functional medicine physicians, because he was less likely to, where at a time in the 1800s when medicine was going more towards pharmacological agents, William Osler was a staunch supporter of listening to the patient and treating the patient, and not just giving them a medicine. So he's one of my great heroes. A quick and dirty adrenal assessment. Keeping in mind that everybody is different, and so somebody might not have a frame of reference. In other words, you might ask somebody, what's your level of stress on 1 to 10, 10 being high, 1 being low, and they may say, well, 3 or something like that, because they may be under a lot more stress than that, but they don't have a frame of reference. They've just lost their frame of reference. So what we do is a very simple blood pressure test. Before we pull blood and measure cortisol, or take saliva and measure cortisol, we do a very simple blood test. It's called the Raglans test, or the orthostatic blood pressure test. The individual, on a good day, average day, not a day that they were up all night studying or they've got a cold or whatever, but on just an average day, the patient lies down, 10 minutes, you put the blood pressure cuff on, you take the blood pressure after 10 minutes, they're not talking, they're not interacting, they're just zenned out there on the table, and you take one blood pressure, you wait 1 minute, you take another blood pressure, you wait 1 minute, they stand up, you take the third blood pressure, and then you wait 1 minute, and you take the fourth blood pressure. What happens when you lie down is that the tubes below your heart, they get to relax, because you're not fighting gravity. But it takes some minutes for that to happen. So I just say 10 minutes because that's an overabundant amount of time for the vessels to open up. And I teach my patients how to do this at home. It's very simple. So you lie down, it takes a little bit of time for the tubes to open up, you take the blood pressure. When they stand up, the blood is falling away from the brain, and it's taking the oxygen with it. So blood is heavy, gravity works, and blood is falling towards the center of the earth. Well, the brain doesn't like that. The brain's going to pass out if it doesn't get the oxygen that it needs. And so what happens is the brain hollers down to the adrenal glands on top of the kidneys, and the adrenal glands holler up at the heart. And as the tubes are closing, the blood pressure should come up. And that's going to keep the oxygen pumped to the brain. So what we're looking for here is, what change is, if I see a blood pressure that comes up, I'm so happy I could bite my toes. It never, hardly ever happens. It either stays the same or it drops or it can even plummet. So if it stays the same, that's what I call mild adrenal insufficiency. And if it drops, say up to 10 millimeter, 10 points, moderate. And if it plummets, down to like you drop 20 points, this individual is in severe adrenal insufficiency. And all of this is really meaningful because when you're in adrenal insufficiency, your cortisols are either going to be too high or too low. And when that happens, you're going to experience signs and symptoms of hypothyroidism. I'm tired in the morning, I'm tired in the afternoon, general sense of fatigue, lethargy, etc. In treatment, we've got to kind of categorize how deeply into adrenal insufficiency someone is so that we kind of know how aggressive we need to be to help them out. Obviously, there's going to be dietary and lifestyle changes. I'm not here to talk about that today. But if somebody's eating a lot of sugar, foods that turn into sugar, they got a lot of inflammation, they have a lot of physical stress. So we need to address that too. But in treatment, simply put, if it's mild, we might want to do something as simple as just Himalayan salt because it's got minerals in it that will support the adrenal glands. If it's moderate, that's when what we call the adaptogen herbs, ashwagandha, scutellaria, holy basil, rhodiola, these kinds of herbs, that kind of comes into play. But if it's severe, and I've had many patients over the years that have been in severe hypoadrenalism, you need to actually treat them with hydrocortisone to save their bacon, get them up and out. They don't necessarily have to be on hydrocortisone for the rest of their life, but until they make their lifestyle changes, until they make their dietary changes, they're going to need some pretty serious support. Little caveat, which you guys I think appreciate. Have a patient who was in adrenal insufficiency, but she wouldn't listen to me. She wouldn't stop her. She's a kind of supersonic queen of the scene. She had high-powered clients in Hollywood and Manhattan and in the military, so she was always on her game. But she was going down, and so she ended up in the ER at one time. They couldn't find anything wrong. They did a tox screen, thought she was on drugs. She ended up in the ER again. She ended up at my house at 5 o'clock in the morning one day. I put her on the couch and started an IV on her. And then she still wouldn't listen. And so she was living alone at the time on 13th Ave in Salt Lake City with a parrot. And she woke up in the middle of the night thinking that she was dying because these people, when they get into severe hypoadrenalism, they literally feel, the term is anergic, no energy. Like they feel like they're dying. I'm not making that up. That's actually how they feel. So she puts a hoodie on, zips it up, gets in her car. She's driving down I Street. She passes out at the wheel. She hits a Hummer. The Hummer is hit so hard that it knocks a tree over. And by this time, the airbag had gone off and burned a great big old Harry Potter scar into her breast. And she stumbles around and collapses on the lawn. Well, by that time, the owners of the house came out and was like, oh my gosh, it's pandemonium out here. They call an ambulance, and she's like a couple of blocks from LD. And so she ends up at LDS emergency room. Again, and they do the tox screen. They do all the workup, cardiovascular workup, everything. They didn't do an ATC-TH challenge. They didn't do that. Won't go into that. So she finally comes to me into this building directly from the ER. Her car's totaled. Her friend drove her. And she sits down in front of me. She says, I am now willing to listen to what you have to say. So she ended up in Cancun or someplace I wanted her to go for a month and to turn her responsibilities over to her mentees, all the people that she was teaching. A lot of her clients got really angry at her because she wasn't available by phone. And I got 2 weeks out of her. She stayed in Mexico for 2 weeks. And I got her on hydrocortisone, and you can talk to her today, and she'd love to tell you the story. She's somebody that you guys know you'll meet. And now she's healthy again, and she's not taking hydrocortisone. But she was going from in adrenal insufficiency you got a lot of green pasture in between. Doctors don't like to hear the term adrenal fatigue, so never use that in the presence of a physician. Always use the term insufficiency. And the reason for that is that doctors don't think that adrenal fatigue is a real issue. Well, if you have Cushing's disease on one side, which is too much cortisol production, round face, buffalo hump, lousy immune system, brittle bones. And then on this side, you've got Addison's disease, which is an inability to make cortisol. That's life-threatening. So this patient that I was just describing, one of many, she was out of adrenal insufficiency going into adrenal exhaustion. She was firmly into adrenal exhaustion, very close, if not in Addison's disease. And there's a way to test for that, but they didn't do that. I've unfortunately made a lot of people angry by saying what I'm about to say. And what I'm about to say does not come from my knowledge base personally. It comes from my mentor's knowledge base that I picked after I got out of school. So going through nursing school and going through medical school, they taught me 3 great myths about thyroid assessment. Myth number 1 is that if your thyroid stimulating hormone, which is something that all doctors do, is within normal range, then then the patient does not need to be treated. That's not true. Myth number 2 is that if you are going to treat the patient, in other words, if their thyroid stimulating hormone is too high and the thyroid is not responding, you want to give them Synthroid or T4 only therapy. I very, very seldom do that because most of the time it's not the right choice. And then myth number 3 is if you're treating a patient, any patient, with any medication, thyroid medication, this makes me a little crazy even talking about it. The therapeutic goal is to get the numbers on paper in between normal range with thyroid stimulating hormone. So I don't do that. And the reason why I don't do that is because it doesn't work most of the time. So a really clear example of that is along the Wasatch Front, we have a somewhat higher utilization of antidepressant use than the national average. I haven't checked recently what it is, but in the past it's been higher. Mostly in women between about 20 and 60. And when I've thought about it over the years, I've thought about obedience bias, because in our dominant culture, none of us, man or woman, is encouraged to say no. And so we say yes a lot. And when we say yes a lot, we get fatigued. We say yes to our families and friends and colleagues, and we get fatigued, but we still continue to work really hard. So when we end up at a doctor's office and we're just saying, man, I'm just tanked, I'm fatigued, I don't have anything left. They take our blood, they're gonna look at the thyroid stimulating hormone, because that's the general screen for thyroid. And they're gonna say, well, you know what? It's not your thyroid, you're depressed, you have a Prozac deficiency, and you get a prescription for an antidepressant. So I don't do that. I prescribe antidepressants to people that are coming to me to get off antidepressants. And then we slowly taper them down. But most of these individuals, depression is part of hypothyroidism. Depression is part of hypoadrenalism. So why do we not look there first? Because there's something we can do about that without using a synthetic pharmacological agent. So we're looking at this slide depicts most of the signs and symptoms of hypothyroidism, which I've already gone through, along with the ones I've already mentioned. People will say, like today I had a patient, she's 37-year-old female with 25-pound weight gain, but she also, when I'm doing a physical exam on her hands and her feet were like ice cubes. And she's just all shut down. So I pulled her blood today. We don't know if she's in hypothyroidism, but if I was a betting man, I would say yeah. The ones that people don't often think about are depression, cold hands and feet, and constipation. That goes along with the greater list that's on the screen. This is just a slide really quickly. I want to just nail down this concept. T4 is the main hormone that comes from thyroid. It needs to be converted to T3 to be a lot more biologically active. But it doesn't only get converted to T3. It also gets converted to reverse T3. Now, I'm not sure why. Reverse T3 test has been around for a long time. It doesn't have to be super accurate, and I'll explain that in a minute. But just remember that the thyroid doesn't just make T4 and T3, or T4 to get turned into T3. T4 can turn into reverse T3, which can fight T3 at the cellular level. It competes with it. Okay, this is what we do with it, and this is the important part. I take those numbers, and I don't trust the numbers. I never have trusted the numbers, nor will I ever trust the numbers. So it's not that I don't care what the numbers are, I do, but I'm more interested in the pattern between the free T4 and the free T3, and the free T3 and the reverse T3. I want to look at the patterns. Where are they? So the speedometer graph goes from 0 to 100 miles an hour. I want to know where that free T4 is relative to the free T3. And what I want to see is that the free T3 is going faster than the free T4. That's what I want to see. So I look behind 3 doors. Door number 1 is production. So we take your blood, we see how much is in there, put it on the speedometer graph, and look at the comparisons. In this particular graph, you see that the free T4 and the free T3 are going the same speed, and the reverse T3 is going slower. So what that basically means for this individual is that they're underproducing because normal does not equal optimal. A normal range of 0 to 100 is normal. Optimal would be well over to 100, maybe even over 100. That's where optimal is. They're all in normal range, but they're low normal, but at least the T3 and the T4 are going equal, or the T3 is going a little bit faster and the reverse T3 is going slower. That's the pattern I want to see. The pattern I don't want to see is that the free T4 is going faster than the free T3, and that the reverse T3 is going faster than the T3. This person not only has a problem behind door number 1, production, they have a problem behind door number 2, which is conversion. You're over-converting from T4 to reverse T3, blocking the energy production T3. And that means you've got a problem behind the 3rd door, which is utilization. So your T3 that you have in your body is not being properly utilized. These measurements are super important. I can't overstate how important they are, but nobody teaches them. So if you understand how to look at your own numbers, you can see if you are in adrenal insufficiency and what you might do about it, if you have a thyroid issue and how you might assess that, and what you might do about that. Because in the case of these guys, this person here is very likely, this person is not over-converting to reverse T3. So this individual would do well on what I call piggy pills. And piggy pills come from desiccated porcine thyroid. They've been around since the 1880s. Most people will have heard of Armour thyroid or Nature thyroid or NP thyroid. It's just desiccated porcine, dried porcine thyroid, standardized to 38 micrograms of T4 and 9 micrograms of T3 across the board, with a few, we've only had a couple of problems in the past. This person, though, this person is over-converting to reverse T3. If you give this person anything with T4 in it, they're going to over-convert the T4 to reverse T3 and continue to block the T3 from doing its job. So if you think about your energy production at the cellular level as a symphony orchestra, T3 is the conductor of that symphony orchestra, and we need that T3 to be dominant. I get often asked, why are there so many people with hypothyroidism? And I'm going to share with you what I think the reason is. And this comes from one of my first mentors when I got out of medical school. If we accept the fact that human beings' average age of death has been coming up for eons, for thousands of generations. So if we go back in time, the average individual is going to live not as long, okay? The extreme age of death has always been, 100 and some odd years old. So you're always going to be able to find somebody that lived to be 100. But the average age of death has been coming up. So my mentor taught me, or he posited a theory. And the theory was this: if you go back in time, say 2,500 years, you're going to meet individuals that lived to a reproductive age that would not have done so 500 years before that. So in today's world, if we go out and we measure 1,000 people, we get 1,000 people, all of whom say that their doctors have checked them for hypothyroidism and they don't have it. So we take those 1,000 people, we take their blood, and we're going to do their free T3. So we take their blood, we bell curve it, and then we 90th percentile it so that 900 of those 1,000 people are within this range. We'll call that range normal range, and in most labs, it's 2 to 4.4. Well, my mentor said, that's right. You're studying a non-optimal cohort, right? So normal would be over here. Optimal. Normal would be here, but normal doesn't equal optimal. Optimal would be here. This is the main reason why in nursing school and medical schools, when they teach the normal stuff, it doesn't work when you go into assessment and treatment. The patient gets missed and not treated, and then they suffer. And so it's my goal to get more people aware of this method of assessment so that they can catch a person with hypoadrenalism or hypothyroidism and actually help them.